I'm Dr. Sharon Bober and delighted to be here today to talk about sexuality and intimacy. I have only one disclosure, and I really want to start by saying that for most people who are thinking about this topic, the experience is often really the elephant in the room. We don't hear a lot about it. The good news is that I think more people are talking about sexual health now than ever, but we know that unfortunately that still means that the majority of folks do not hear a lot about this topic from their clinical team. As if you've ever heard me speak before, you know that I often find it kind of an interesting paradox that we live in a culture that's certainly saturated with sexual images and lots of sort of sexual ideas that we see on TV and movies. But the fact is, we don't really talk about real sex and real people. There's often a fair amount of confusion on a clinical team who's responsible for initiating this topic. And often there's a fair amount of misinformation. I will also note that most clinicians simply don't get any training in terms of talking about sexual health, and often aren't sure what to say when somebody endorses a problem. And often that is the reason why people don't sort of start that conversation to begin with. That's a lot to take in, given that sexuality and intimacy is probably one of the first aspects of normal life that gets disrupted in the context of either cancer treatment or risk-reducing surgery. We know that some of these challenges are often long-term or enduring after treatment. And what we also know is that the majority of women say they simply would have liked more support for this topic. So whether it's about body image or how to talk with one's partner or sexual health more broadly, there is absolutely a need for more support. So I want to sort of sit with you today and really sort of think about what I mean by talking about sexuality to begin with. I'm really thinking about that as a biopsychosexual experience. So what does that really refer to? Well, when we think about sexual health and sexuality, it really is at that intersection between physical experience, mind and body experience, and also takes into a context cultural experience and relationship issues. And really sexuality is at that intersection. So when we think about whatever it is that's getting disrupted, it's really important that we take a broad picture, big picture view, and we sort of take an integrative perspective because we know that all of these factors are very much in play. In addition, sexual health is really a human right, a human experience across the lifespan. And I think it's important to clarify that there is a very wide and normal range of sexual function. There are lots of different levels of meaning and importance that are variable. But more importantly, if there is something different that is bothersome or distressing for you, or if there is a change or potential for change that you're worried about, it means that this aspect of your life deserves attention. And that even if your doctor or your clinical team may not be bringing up the topic, it does not mean that one, there's not help available, or two, that it is not a very valid and important topic for you to advocate about. And the reality is that the impact of all of our treatments have the potential to disrupt sexual function. So whether that's surgery, radiation, chemotherapy, hormonal therapy, preventive surgery, prophylactic surgery, all of these treatments have the potential to have an impact on sexuality. So today I really want to focus on the most common concerns. Really, if we sort of think about those categorically, for women, we often think about issues or changes in body image, perceived body image and self-esteem. A lot of symptoms that sort of fall under the big umbrella of menopausal symptoms, or what we call the genitourinary symptoms of menopause. We think about the category around desire, arousal, and sexual satisfaction. And then there's the kind of a context around in relationships. So whether that's somebody who's in a relationship, changes in intimacy, concerns about dating, starting a relationship, really the sort of social intimate issues that come up that are not just individually focused, but part of an interaction with another person. I also want to say that my perspective for anyone who's thinking about this topic is that it's really important to be proactive. We know that when there is sexual dysfunction, sexual disruption, first of all, those symptoms are often associated with not just distress, but anxiety, loss of self-esteem, relationship distress. And we also know that many of these issues do not self-resolve. So as opposed to other side effects of treatment, often symptoms of sexual dysfunction do not get better over time by themselves. And that means that people have to get educated and people have to get proactive about this aspect of care. And again, even if a provider isn't starting the conversation, I think it's essential that people become advocates for their own experience in this, and that we really take a kind of a proactive approach, both in terms of being prepared and in terms of rehabilitation. So let's start with body image and self-esteem. I think that often this is a topic that is very relevant for women, and that we often do not bring the same sense of compassion for ourselves that we immediately have when we're thinking about a friend or a family member. And I think especially when it comes to body image, it is pretty common that women struggle with body image and kind of self-judgment, really starting very early on across the lifespan. And I think that in the context of BRCA or of prophylactic surgery, of cancer treatment, or of any hereditary cancer where people are doing preventive surgery or screening, we really need to think about what it means to be able to explore our sense of self without judgment, without being heavy-handed, and again, sort of thinking about cultivating a sense of self-compassion, maybe similar to how we immediately might think of caring or being compassionate for a friend. So even in the face of loss, when it comes to body image, I think it's really important to focus on what our bodies can do rather than what our bodies look like. I think it's important to think of what we can do to have a sense of compassion for how our bodies have gotten us to this place today, rather than only focusing on how other people might sort of represent what a body is supposed to look like. And I also think it's really important to remember that sexuality and being sexy and sexiness is simply not driven by any one body part. It is very much a function of who we are, of the energy that we have, of the whole and totality of our experience, much less so than about just how you look in a bathing suit or a scar or a particular body part that is either lost or different. And really from that point of view, we have to begin to reimagine this new sense of self in this new body with a sense of kindness. So often in terms of when we think about where to start, focusing on strength and health is a really important place to start, meaning that you may not have to love every part of your body, but you can certainly get active as a way to feel strong and as a way to feel whole. So whether that is something like exercise in a traditional sense, or whether that's doing yoga, or whether that's going dancing, I think just moving one's body and getting active in the body and being able to feel grounded in our body without feeling panicky is a critically important place to start. And similarly, those opportunities give us a sense to reconnect with sensation and with curiosity about sensation, where we can experiment with that and sort of figure out what feels okay and what doesn't feel okay. And I think importantly, focusing on that sense of pleasurable sensation, feeling about that sense of creating opportunities to feel strong, rather than waiting to feel better about our body, is an important way to begin to jumpstart an experience where we feel whole again. Going to switch gears to another common problem, and again, just giving a little bit of a taste of each of these topics, that we can be exhaustive in a half an hour. I want to switch gears to thinking a little bit about menopause, and very specifically, all of the kind of common concerns we have about vaginal health or common genitourinary symptoms of menopause. I would say the common category for women is that whenever we have any kind of significant significant estrogen loss or depletion, we have changes in often genitourinary health, and specifically vaginal health and urinary health. So we know, for example, that the genital tissue thrives on estrogen, and that when we lose that estrogen, there are all kinds of ways where we may lose not just lubrication, but elasticity and blood supply to that tissue. Often people notice that they have discomfort or pain with or without sexual activity, itching or chafing or burning. There may sometimes be a vulnerability to inflammation or infection. And we also know that when we go through menopause, we lose about half of our testosterone. And again, often women have urinary symptoms, whether that's urgency, frequency, and don't even make that connection that the urinary system is often, again, has a lot of estrogen receptors, which changes when we go into menopause, whether that's short term or longer term. So I know there's another talk that's being given on menopause in particular, so I'm not going to go into too much detail. But I would say from the sexual health perspective, it's a really important thing to get educated about what it means to restore vaginal health. Very specifically, in our clinic, we think a lot about what it means to help women adequately restore moisture and stretch and blood flow to that genital tissue, again, in order to have good vaginal health with or without sexual activity. And I think that's a really important point. This is just as relevant whether one is partnered or whether one is sexually active or not. So to start with, I think all women need to know what to do to manage dryness and to restore moisture to that tissue. I think this is just as important whether you are concerned about having a GYN exam as any kind of sexual activity. They're often connected, but not the same. And I think that, it's really important to get educated about how to restore moisture. So, again, thinking very quickly and broadly about the fact that women often hear about using a lubricant, but that is different than a vaginal moisturizer. Vaginal moisturizers are specifically formulated to hold water in that tissue. Similarly to how we often talk about using a moisturizer on our hands or our face, there are moisturizers formulated for that vaginal tissue. We know that good vaginal moisturizers actually work well. Often women need them. Some women use moisturizers daily. Some women typically use moisturizers 3 to 5 times per week before you go to bed at night. Helps that moisture soak into that tissue. It's important to get educated about lubricants appropriately. We often recommend, for example, water-based lubricants, lubricants that are glycerin-free. And then thinking about, again, making sure that we notice that the vulva, the external tissue, needs to be moisturized as well as internally. So whether that's using something like coconut oil or a small amount of vaginal moisturizer externally, really important to moisturize both internally and externally. And then I will also say that for many women, vaginal estrogen or vaginal DHEA are both totally acceptable and good options. They are not systemically absorbed, and also can really help if over-the-counter moisturizers are not adequate enough, and would recommend people speak with their medical provider, specifically their doctor or nurse, to talk about that possibility as well. I'm not going to go into any great detail about this slide, except for just to say that there are additional sort of new options that are online. Specifically, I want to mention the CO2 laser, which is a kind of a novel treatment in order to address vaginal dryness. This is now in clinical trials, specifically starting a large clinical trial for women after breast cancer. Anecdotally, we know that some women have found this to be very helpful, but we also know that when women have very delicate tissue, when there's atrophy, the CO2 laser may not either be effective or may not be helpful. That's something that I would say the jury is still out. Insurance does not pay for that, and we still have questions about efficacy over time. So again, I would say that these are some options that we're still sort of studying, and I would say that there is more information coming. But again, certainly in terms of using vaginal estrogen, vaginal DHEA, those are two options which we often use. They're considered to be safe and are not systemic absorption, is not HRT. And I think that would be something to talk with your doctor about. More importantly, or as importantly, women need to learn about the pelvic floor. So I would say that if anybody hears anything, they hear about using a lubricant, maybe they hear about a moisturizer, but lots of women who have any discomfort or pain with or without sexual activity often do not get the benefit of information about the pelvic floor and the need for pelvic floor rehabilitation. We work very closely in our clinic with our pelvic PTs because the pelvic floor muscles are incredibly important for sort of, I would say, good, not just urinary health, bowel health, and sexual health, but really this is something that women need to be aware of. Often women never hear about the pelvic floor except for people are told to do a Kegel exercise after you have a baby. And that's really about clenching those pelvic floor muscles and making them more toned. What often happens on the other side of menopause is we lose our capacity to keep those pelvic floor muscles engaged when they need to be engaged. So you don't want to be peeing when you're coughing or laughing, but you need them to be relaxed when you want them to be relaxed. And so learning about pelvic floor rehabilitation is a super important part of sexual health rehab that we often, we again, working hand in hand with those pelvic floor PTs. So these are physical therapists who have specialized training in doing pelvic floor rehabilitation. So again, this is about a rehabilitation slide. So the point is that some of this work may be done with a pelvic floor physical therapist. Some of this work can also be done by individuals themselves without a PT. So learning to do some relaxation of the pelvic floor, learning how to do that sort of muscle toning and relaxation exercise. We also have a number of different strategies that we also use. So for example, vaginal dilators, you can see a set on the screen. They are a set of cylinders that are graduated in size, where women can gently and methodically learn to get some stretch back to that tissue. And again, when we sort of think about the range of strategies that we have, we actually have a lot. So I would say that pelvic floor rehab is probably one of the least well sort of publicized strategies that we have. And this is something that is now getting a lot of traction and understanding. Fantastic YouTube videos now that have been put up by a number of PTs. So check that out. And last piece around vaginal health is that we really need to think about getting good blood flow to that tissue. We talk about this in terms of male sexual rehab all the time, but we don't talk about this in terms of women's sexual rehab nearly enough. Really important to get good, healthy blood flow to that tissue. And I would say anything you can do to get a clitoral stimulation that feels pleasurable also is allowing you to get nerves firing and good blood flow to that tissue. And that's really an excellent strategy for both helping with improving orgasm and improving general health of that tissue. So in short, vibrators are feel good and are good for you, using whether that's manual stimulation, using a vibrator. I mean, really anything you could do to think about getting blood flow to that tissue is actually really healthy for the tissue as well. I will also just say that for any woman who is having dryness, for any woman who is having muscle tension or clenching, we also know that there is most likely going to be pain or discomfort with any kind of sexual activity. And, in a very kind of clear way, when you have pain and you have discomfort, you're going to have low desire. Most women have no desire to do something that's going to hurt. And we know that that leads not just to anxiety or fear of pain, but that really leads to avoidance, that really leads to wanting to sort of not think about sexual activity. And that leads to a loss of desire, right? Sort of a loss of arousal and low sexual satisfaction. So low desire is certainly the most commonly reported sexual symptom. I would say that most of the time in our clinic, when we start to do a little bit of a history, what we find around low desire is often there is an issue around pain or discomfort. And that is so important to address, because trying to do some quick, easy solution to having a low desire problem fixed, if you're still having discomfort or pain, doesn't make a lot of sense. And I think it's important to start with that vaginal health first. So definitely want to address that as a first step in terms of addressing low desire. But I will also say there's more to that story. So, when we think about low desire, originally this is a kind of a representation of an early model by Masters and Johnson, with this idea that, people sort of have desire. It's kind of spontaneous, automatic, like a light switch. And then you have a stimulation, you reach an orgasm, and then you kind of move, relax and move on to the next time. But for women, it's actually a lot more complicated. And I know this is a bit of a complicated slide, but the idea here is that actually there are lots of ways that women have the experience of wanting to have sexual activity. It doesn't come just from an automatic light switch experience of, oh, I see something, I'm in the mood. But actually, often women have to have an experience of feeling close, feeling connected, feeling intimate, feeling touch that feels good, in order to jumpstart an experience of desire and to sort of get desire to kind of take off the ground. So the idea here is that spontaneous desire happens sometimes, but for most women over the course of a lifetime, by the time you get to midlife, by the time you get to having kids, or get to having the same partner for a long time, or you get to having work and a job and stress, desire is something that shifts from an automatic experience to an experience which needs to be cultivated. And certainly Dr. Lori Brado has written in detail about this idea that desire is not something that we expect to be spontaneous over a lifetime. And when we don't have spontaneous desire, that in itself is not a psychological pathology. That is not a problem. It just means it's a challenge which we need to address. So how do we do that? So, well, first of all, I will just say, so here my myth slide about desire. Desire is not portrayed, desire is portrayed in movie scenes like it is just automatic. People are in the mood at the same time. People have orgasms at the same time. It's exactly perfect and out of the blue. Like, that's lovely, but that's actually not true. Desire doesn't work like a light switch. And that actually, if we have to plan for it, it can't be good, right? Like, those are the sort of myths that we see. And so I think, to the point I want to say here is that certainly when women have automatic negative thoughts, like there's something wrong with me, somebody's not going to find me attractive, I don't have the same feeling that I used to, that can impact, our willingness or desire to have an experience that is pleasurable. And I think it's really important to really appreciate that anticipation rather than spontaneity can be a wonderful perspective. So that rather than thinking, well, I'm not in the mood, so I'm not in the mood. Sometimes really take the perspective that if you feel kind of neutral about the whole thing, but you imagine having an experience which would be pleasurable and non-pressuring, right? But on the other hand, romantic or exciting or fun or curious, it can allow somebody to have an experience that is intriguing enough that you want to have a little bit more of it, right? So it really can build on itself. So I would say, we need to harness the power of the mind. We need to think about those automatic negative thoughts and how we might replace those with other kinds of thoughts. We actually need to sometimes really kind of do some exercise to get in the mood about thinking in a sexy sort of way, right? We need to kind of notice what is around us, which kind of gets us in the mood, or have an experience which is sensual, or literally something about smell or touch or sensation that just allows us to feel sexy. That's not necessarily about sex, but that allows us to feel a sense of sensuality. And I would just say that, the important thing is that there's actually a lot of fantastic material now that is pro-sex, pro-women, sex positive, whether that's erotica, video, fantasy, and that you don't have to kind of make this up by yourself. So number of excellent websites, short stories, books that are written that are, again, very sort of sex positive and pro-women. And I think that's very different than porn. So I would just say, let me just go back for 1 second to say that, low desire is for sure a distressing issue, but it is okay that we don't have a magic pill for that. There are a couple of FDA approved drugs that are helpful to some women, but for the majority of women, low desire is not something which is easily solved by a pill. And I would say, as a psychologist, that is totally okay with me, because there are many different ways in to increasing low desire. And I think what's important is to recognize that there isn't just one thing we can try or do, but that there really are a number of different strategies to allow us to, again, harness the power of the mind, make sure that our bodies are healthy, that our vaginas are in good health and well-being, and that we are able to sort of move forward with cultivating this experience. Lastly, I want to talk for a minute or two about relationships, because I think that, especially in the context of cancer, cancer risk, relationships can get stressed or disrupted. And that I think sometimes we really have to figure out what the goals are with our partners. We have to increase communication and really have a plan for creating a new chapter. I'm not going to go into any great detail here, but this is to say that we really have to shift our focus on what is pleasurable and what is sensual, rather than thinking about sex as a military campaign, because I don't think that's a turn on for anybody. I think we have to start slowly. We have to sort of expand the repertoire. Sometimes that means trying things we haven't tried before, or going slowly, or focusing on focusing on what we would think of as being almost like the outer course, or what we call, the kind of, kissing or touching, or the things that maybe not have been the main event as the main event. And really sort of knowing that there is help out there. So for couples in particular, if couples are stressed, if couples are struggling, it might be a good time to check out working with a therapist that can help increase communication and help people sort of think about a plan or an action plan for moving forward. So really last couple of thoughts on this is that I think it's important to acknowledge and accept loss and change, and really to sort of think this is a time of creating a new normal, of creating an action plan where you sort of figure out what your goals are and what you and your partner want to try to talk about together in terms of slowing down, taking your time, and more importantly, often sort of anticipating or planning for time to kind of be together, rather than just assume that needs to be spontaneous or automatic, and to really shift our focus on pleasure and sensuality. Last point here is that please talk with your team. Even if your provider is not bringing up this topic, ask about how any treatments might have the potential to impact sexual function. Ask about anything that you need help with. Say, listen, do you know who I can talk with? Is there a gynecologist that specializes in menopause? Is there a therapist or counselor that I might be able to talk with or without my partner? Don't hesitate to advocate for this topic. And again, really sort of access the resources that are online as well. I would say, in terms of both books and digital resources, I'm excited to say that we have more resources now than ever. Certainly the Dana-Farber and the Sloan Kettering Cancer Center in New York both have a lot of resources online, as well as others. So don't be shy to advocate for this, and really just delighted to be here with you today. Thanks so much.